Yeah, okay. So I'll go straight away to my case. So this is a case of a 46-year-old lady. She was the sister of a consultant in our hospital who came to us with a gradual diminution of vision in both eyes for the last 1 week, along with some discomfort. She also had a very troubling headache, tinnitus, and unsteadiness in her gait. She had no other systemic history. What she did give us was a history of COVID vaccination 2 weeks ago. So when she came to us, her best corrected visual acuity was 618 in both eyes. She had cells at a few kps. The fundus, there was vitritis. They were around grade 1 to 2 vitreous cells. There were these pockets of subretinal fluid, these neurosensory detachments here in the peripapillary area. And you can see these ILM folds. That was the right eye. This is the left eye, which had a similar picture. So there were these pockets here of neurosensory detachments. We did an angiogram, and the angiography, you see these punctate pinpoint areas of hyperfluorescence. So these areas of hyperfluorescence, they increase, and in the late phase, you see the pooling of dye in the areas of the neurosensory detachment. So just these are the pictures in the late phase of both the eyes, these punctate pinpoint areas of hyperfluorescence, along with pooling of dye in these areas of neurosensory detachment. So this is the typical starry sky picture on fluorescein angiography, where you get these pink point punctate staining, hyperfluorescence. The OCT showed a corrugation of the retinal pigment epithelium, and you see these elevations corresponding to the neurosensory detachments. So on the other cuts, there were multiple such elevations causing a compartmentalization of the retina. And putting all these things together, our clinical impression was a Vogt Koyanagi Harada syndrome. So the patient had bilateral uveitis, no other systemic history, and the typical features of angiogram and OCT. Systemic investigations were ordered, and all these were negative. So the patient was started on oral steroids. High dose steroids are given for VKH. So she was around 60 kgs. So we started around 80 milligram prednisolone daily, along with eye drops. 2 weeks later, she had a dramatic improvement. Her vision improved to 6/9. You can see the areas of neurosensory detachment had almost gone. When the OCT, this is the left eye. On the OCT, you see those, the neurosensory detachment had come down, the foveal contour was restored. At this time, the patient was very apprehensive about the oral side effects of steroids, so we tapered it down to 60 mg, and that is what I usually do in my practice. I give 80 mg for 2 weeks and then taper it down to 60, which I then keep for a pretty long time. 1 week after being on 60 mg, the patient came back to us again with a drop in visual acuity. Her inflammation had recurred, the areas of neurosensory detachment recurred, and this time more aggressively. So you see the OCT again shows those compartments, those loculated fluid. At this time, we advised admission to the patient. I realized that this patient would require a much higher dose of steroids, so she was admitted for IV methylprednisolone, 250 mg QID for 3 to 5 days, depending on the response. After 2 days of intravenous methylprednisolone, she did show improvement. The fluid started going down, the inflammation started resolving, her vision started improving. So at the completion of 5 days of therapy, there was still some fluid persisting here. The inflammation had gone down, the neurosensory detachments had gone away. So she showed a very good response to IVMP. At this time, a rheumatologist consultation was obtained. We thought that we would like to start the patient on immunosuppressives, and she was started on methotrexate 7.5 milligram per week. And the rheumatologist planned to increase this later, depending on the patient's tolerance to this dose. This is 2 weeks later. You see that the foveal contour is restored very well. The patient's vision went up to 6/6, both the eyes. A month later, she maintained this vision. There was no inflammation in the retina. So on follow-up, after this, her oral steroids were gradually tapered over the next 6 months. The methotrexate was increased, and now she's on a dose of 20 milligram per week. She's now been with me. I saw her just before coming. So 8 months later, she maintains a good vision. There is no inflammation. The foveal contour is excellent. She is fortunately tolerating these medications well. So she's been advised a monthly hemogram and a monthly LFT because she's on methotrexate. And right now, we have stopped her steroids and she's only on methotrexate. So to sum up, just to give you a few pointers from this case, so VKH is a bilateral panuveitis with multiple exudative detachments. Any case of panuveitis that we see, there are only two conditions that we think of very commonly. One is VKH and one is tubercular uveitis. But tubercular uveitis generally would not have those kind of exudative detachments. And so the only common conditions that we see with exudative detachments and bilateral panuveitis is VKH. Of course, the uveitis could occur one by one. It may not occur simultaneously. It could occur one eye and then there could be a time lag. VKH has very characteristic features on FA, like I told you, those that starry sky appearance, and on OCT, multiple areas of loculated fluid with compartments. VKH can occur following infections, viral infections, so do take a history of viral infections. And more recently, I have seen a lot of cases following COVID vaccination and even COVID fever as such. Now, the mainstay of treatment is a high-dose steroid therapy, and the point to remember is that the steroid therapy has to be tapered extremely slowly over 6 months. So the moment you taper your steroids and come down to a low dose, the patient will have a recurrence. So the taper has to be very, very gradual. Recurrences are common, especially if you've tapered the steroid very fast. And immunosuppressives should be added. Now, that is also controversial, but most people like to add immunosuppressives to prevent recurrences. And different people have different choices. In our center, the rheumatologists do like to start methotrexate as the first-line immunosuppressives. So with that, I come to the end of my case. And again, to reiterate, the meeting in Abu Dhabi, so request all of you to attend. Thank you so much.
Thank you. That was a really a very nice case, and I think shows very typical history and clinical features of VKH. To me, the most important point is exactly what you were saying about needing to add in an additional immunosuppressive drug, because these patients do need treatment for a long period of time, often, as you say, 8 to 12 months or more. And the real problem that we now realise, of course, are the longer term side effects of oral steroids. So we should be trying to minimise the steroid dose, and a drug like methotrexate is usually well tolerated, and we often use a dose of 20 milligrams or even 25 milligrams weekly, and it's very effective in a disease like this. Yeah.
Thank you.
Thank you.
Thank you.